Hi, it's Dr. Centeno, and thanks so much for joining us today. Got an interesting topic, understanding how Chiari causes symptoms. This is an interesting one for me because I've seen for many, many years patients with Chiari 0, CTE, patients with Chiari 1 and beyond. And many times they often have other things that seem to be causing their symptoms, not necessarily the Chiari. So I thought this was a good time because there was a research study published about 2 weeks ago that went into depth on what causes Chiari symptoms. And it was not what you'd expect, right? You would think that what causes Chiari symptoms is the descendants of the cerebellar tonsils into the spinal canal or foramen magnum. And interestingly, I don't know that we have much data that supports that. So it allows us to rejigger, if you will, how we approach Chiari patients. And so we'll get into that today. As usual, I'm going to spend a bunch of time, maybe 15 minutes, 20 minutes max, going through the information that I want to present, and then we'll get into Q&A. On the Q&A side, that's really ask me anything. Ask me anything about this topic, ask me anything about another topic, whatever you want to do. It really doesn't matter to me. The topic is really just something that's of interest to me and many patients. But when it comes to actually asking questions, if you've got a question about something totally unrelated, anything's game here. The goal of these presentations is to educate patients, and to educate patients not only with didactic material, but also by allowing patients to ask questions, because all too often in today's medical care environment, questions don't get asked of the doctor. There's just not enough time. So this is my commitment to providing time to answer questions, because a patient who has lots of questions and gets those questions answered, in my experience, is better educated and more likely to do well with any procedure or anything, any treatment plan. So let's get into it, understanding how Chiari causes symptoms. Okay, so just so that we understand here, Chiari is when the back of the brain descends. And if this is the skull and the yellow here is the brain, and we draw a line across the foramen magnum, then if the cerebellar tonsils back here are above that line, that's not Chiari. If they are touching that line or close to that line, really touching or up to 5 millimeters below, then that's CTE or Chiari 0. And CTE means cerebellar tonsillar ectopia, kind of a big, long medical word. And then if the cerebellar tonsils have descended more than 5 millimeters below that line across the foramen magnum, then that's Chiari 1. And those are the two main players we'll talk about today, CTE and Chiari 1. There are other definitions to get into Chiari 2. But this is mostly what patients who are seeking care for Chiari end up delving into, or the classifications where they live. So do we really know how Chiari malformation causes symptoms? Now, it's interesting. You would think we know for sure that Chiari malformation causing symptoms is in fact related to this right here, right? I mean, that's what defines Chiari, that the cerebellar tonsils descend too low, and that has to be what's causing symptoms, right? And the answer is we really have very little high-level evidence in Chiari as to what causes symptoms. You would think that's not the case, but if you look at the research, that's pretty much the case. There are a bunch of theories about what causes symptoms. Some theories have more evidence than others. But it's interesting that we don't know for sure scientifically. So you might be saying at this point, wait a minute, I heard it's the stopper effect. So let's go over the stopper effect. The concept is like a stopper on a bottle, right? The concept is that when we put the stopper on the bottle, nothing can get in or out of the bottle. Now, if we look at that for a second, the cerebellar tonsils are going to be the stopper itself. And the bottle, in this neck of the bottle, is going to be the foramen magnum and the spinal canal. So if the cerebellar tonsils descend into the bottle, so to speak, or into the spinal canal or foramen magnum, then that's going to stop that cerebrospinal fluid flow that's so essential. So that seems to make some sense. Now here we have a cine MRI or a CSF flow study. And what this is looking at here is the cerebrospinal fluid flow around the brain. And the brain has cerebrospinal fluid that circulates through the brain and around the brain. And at the bottom here, where this stopper effect can happen, we can actually now do MRI studies that allow you to see something like this on the right, where as you see the white back here, or the light gray color, that shows there's cerebrospinal fluid flow. But on this side, there's more of a stopper effect, and you don't see that cerebrospinal fluid flow. So that's the leading theory as to what causes symptoms in Chiari, that it's a stopper in a bottle, and we are disrupting that normal cerebrospinal fluid flow. But maybe not. I'm going to go over two studies. And this study would question it entirely, right? They actually took patients with Chiari 1 who were symptomatic and patients with Chiari 2 who were asymptomatic. And they looked at that peak CSF flow near the foramen magnum, and it regrettably didn't differentiate the symptomatic from the asymptomatic patients. And that's really the sine qua non. That's really the main thing in these diagnostic studies, right? In order to use a diagnostic test and say that diagnostic test proves someone with symptoms, you have to do these studies with asymptomatic and symptomatic patients. And you have to have something that you can point to that is only in the symptomatic patients that differentiates them from the asymptomatic patients. Now, this study is a little more convincing, but the problem is they compared Chiari 1 to CTE, and this difference for abnormal flow is pretty measly, right? It's not like the CTE asymptomatics had 5% abnormal flow, and the symptomatic abnormal flow for Chiari 1s was 76%. There's only about a 14-point difference here. So not a super convincing study that CSF flow, due to the stopper effect, is causing symptoms, and even less convincing because they took Chiari 1 and they compared it to CTE. So they really needed to take Chiari 1 symptomatic versus Chiari 1 asymptomatic. That would have been a better determination, like the other guys did. And we know that there's a lot of people walking around with Chiari 0 or CTE or Chiari 1 who have no symptoms at all. And this was a pediatric study, but the other studies are very similar to this, right? If you take the prevalence of Chiari 1 in particular, it's about 1% of the general population. Some people would have it as high as 2%. So if we take that for the US, that means that we've got 3 to 5, 6 million people walking around with Chiari 1. And we certainly know there aren't 3 to 6 million Chiari 1 patients in the United States. So again, there's a lot of people walking around that have this and have no symptoms. So you have to intellectually ask yourself, what's the deal there? What's separating that? So the research suggests something that's much more interesting than just looking at an MRI and seeing Chiari or not, and then claiming that what you're seeing on the MRI is causing the symptoms. The research actually looks something like this: Chiari plus something else equals symptoms. If you don't have the something else, you don't get the symptoms. And so again, I'm going to come back to this a couple times. Chiari plus something else equals symptoms. So what is this something else? Now, there's probably a lot out there to be discovered, and there may be one or two things out there that I don't know about, but based on my review of the literature, there's two things that we know that are something else. One is craniocervical instability. The other is rectus capitis posterior minor atrophy. So those are the two things we know about right now, or at least we know about that I know about. So Chiari 1 plus CCI, this was a 2022 study where they tried to answer this question, right? Why do we have asymptomatic Chiari people walking around versus symptomatic? And can we look at something on their imaging that allows us to figure out who belongs in which group with high accuracy? Because if we can do that, then we can start to figure out how to treat these patients. So as you can see here, with regard to this, the type of craniocervical instability we're going to be looking at is what I call CCI type 1C, or C0C1 translational instability. And that's a translational BAI of 4 millimeters or greater. That's just skull sliding. So here I've tried to illustrate that the skull is sliding on the cervical spine. So that's the kind of CCI we're talking about. And interestingly, they came up with a rather unique view of this, right? They looked at the shallowness of the C0C1 facet joint. Normally, the C0C1 facet joint is more of a shallow ball and socket. And what they found is that there was more of a ball and socket than that defined the asymptomatic patients. And if there was less of a ball and socket, meaning the joint was shallower, then that defined the abnormal or symptomatic patients. So makes sense, right? If you have this deeper set 0-1 joint, you're going to have intrinsic bony stability that doesn't really matter what happens to the ligaments. You're going to have pretty good stability there at that joint because the bones will allow for it. But if you're born with this shallower occipital condyle and you get some damage to those ligaments or the muscles, then you're going to get more movement because that allows more movement. So again, a flat 0-1 joint defined the Chiari symptomatic patients here, whereas a more deep set ball and socket type 0-1 joint defined the patients who had no symptoms. So just to reiterate here, now our sliding type CCI happens due to a shallow C0C1 facet joints that then irritates the cerebellar tonsils and cranial nerves. Without the Chiari, doesn't do that. With the Chiari, it does do that. So again, going to come back to that same equation. Chiari 1 plus, in this case, shallow C0C1 facet joints equals symptoms. You don't have the shallow C0C1 facet joints, you don't get symptoms, even if you've got a Chiari 1. So again, going to keep coming back to this equation. And I think this is where Chiari research is going to head over the next 5 to 10 years, is what is the something else and how do we treat that something else? I think we're going to see a dramatic change in Chiari research. So this is the one that I've been discussing with many Chiari patients over the last couple of weeks, this rectus capitis posterior minor study. And what these guys did is they asked the same question. Could it be that one of the something else's is in fact denervation of the rectus capitis posterior minor? And you're like, what the heck is the rectus capitis posterior minor? That sounds like some sort of crazy medical term for some sort of crazy muscle I don't know about. So let's delve into that. So the rectus capitis posterior minor here connects to the myodural bridge, which is here. So this is the muscle, and it connects through this myodural bridge, the covering of the brain and spinal cord. So this light blue here is the covering of the brain and spinal cord called the dura. So that's interesting, right? Why would it connect? And I got to get rid of some timings here, guys. I apologize. I will be right back here. Let me get rid of those timings. And we'll go right back to where we were which is this slide here. Okay, we're back. So anyway, we've got this crazy little muscle in the back of your head. It connects, interestingly, into the brain and spinal cord, or the covering of the brain and spinal cord. So why would that be? That seems like an odd connection, right? Between a muscle at the back of your head. Think about that. That connects into the covering of your brain and spinal cord. And if we draw it out more exactly here, we've got this rectus capitis posterior minor that goes from the skull. It goes to C1. There's the myodural bridge, which is this connection, and that connection goes to the brain and spinal cord. Then we would have a low-hanging cerebellar tonsil right here. Now, CSF flow in Chiari would be minimal flow getting past that descended cerebellar tonsil, right? That makes sense. That's that whole stopper effect that we tend to see. But interestingly enough, even when that stopper effect is present, it turns out that this rectus capitis posterior minor has a role to play. And its role to play is actually when you contract this rectus capitis posterior minor, it pulls that dura out of the way. And by pulling that dura out of the way, it allows flow to happen. So in cases where you might have increased intracranial pressure up here, you can reflexively contract that muscle, which opens the gate, if you will, for cerebral spinal fluid to flow out, despite having Chiari. And that's the key here. This is the back door, if you will, to cerebral spinal fluid flow. And if you've got an intact rectus capitis posterior minor muscle, it opens the back door. And it doesn't matter that you've got low-hanging cerebellar tonsils because the back door is open for the cerebral spinal fluid flow. But what would happen if the back door didn't work anymore? And that's really what this paper talked about. And that is, if this muscle gets atrophied, and I've drawn a much, much smaller muscle here, now all of a sudden it can't open the back door. So when there's increased intracranial pressure, it backs up. So now we have more of a nuanced look at this whole stopper effect, right? And the whole cerebral spinal fluid flow theory. It turns out that it's not so much about the stopper as it is the back door that gets around the stopper not working anymore. And that's what that paper really focused on, is if the back door doesn't work, that's when you get problems. Not because the cerebellar tonsils are low. Now, the cerebellar tonsils being low sets up the condition, but it's not the cause of the symptoms. It's just the setup for the condition. And that's why this is important. So again, atrophy of the RCPM, that should be RCPM, eliminates the back door to normal CSF flow, and that's worsened by Chiari. Again, Chiari 1 plus this atrophy equals symptoms. So we're coming back to that. So there's probably more to this story to be told. I would imagine over the next 5 years, we'll see much more research into the something else as to why patients get symptoms in Chiari. And there are probably going to be other something else's that are discovered here. And there may be others out there that are in the process of being papered right now, if you will, with the proper research. So again, how do you get rid of symptoms? If you have Chiari, treat the something else first, because that's where the data seems to be pointing as to what causes the symptoms. The Chiari is the setup. The something else is the problem. So you could say the Chiari is the fire and the something else is the gasoline on the bonfire that gives you symptoms. If you just have Chiari, you don't get symptoms if you don't have the something else. If you add the something else in there, you get symptoms. So it would make just common sense to treat this first and then treat that last. If you treat this first, in my experience, many patients with Chiari don't have symptoms. Their symptoms go away or their symptoms become manageable. But if you do this, i.e. with posterior fossa decompression and a big surgery, there's no going back. You can't treat the something else generally at that point. So you got to do the something else first and the big surgical decompression last. So how do you treat these issues? Well, we've been doing it a long time by treating craniocervical instability through that PICL procedure. Obviously, you can also get a fusion there, but that's a big surgery, just like the posterior fossa decompression. And then if it's this suboccipital nerve, let's dive a little deeper into what that is. So there's a suboccipital nerve here that innervates these muscles that we've been talking about. That's this one right here. And what they determined in that research paper was at the end of the day, the suboccipital nerve seemed to be the cause of the problem because the muscle was atrophied. So think about someone in a wheelchair after a spinal cord injury. Their muscles shrink up. Now they can exercise those muscles all they want. Those muscles are never going to get bigger because the nerve that goes to those muscles is dead. And that's the problem that these researchers identified. So if we're going to treat this in Chiari patients, we got to treat that nerve. Absolutely, that nerve needs to be treated. Now, for us, we've treated lots of nerves for many years using platelet growth factors injected around the nerve. There's some good research showing that that works around other nerves. And so that's one component, right? Treat the nerve. The other component, obviously, would be once the nerve starts to come back, work the muscle. So this is some research we did in our office trying to figure out, is it chin tucks that get these muscles going? Is it looking up? Is it bending your head? Versus a Valsalva maneuver. A Valsalva maneuver is forcibly exhaling against a closed airway, kind of bearing down. And it turns out that that Valsalva maneuver is the best way to get this muscle activated. So if we look at our research on that, this is the muscle right here. You can see it activating quite nicely with a Valsalva maneuver. So again, watch that again. This is the muscle. This is the muscle. You can see it activating quite nicely with that Valsalva maneuver. So at the end of the day, we want to work the muscle. So treat the nerve plus work the muscle, I believe, is the way to deal with this particular issue if you've got it. And how you work the muscle is this Valsalva maneuver, not with moving your head, it seems like. So again, in summary, Chiari plus something else equals symptoms. Keep coming back to that because I think this is where the real money lies here, if you will, meaning this is really where the real efficiency in trying to treat Chiari probably lies. Treat the something else first before surgical decompression. And we've been obviously doing that for quite some time now, and we're going to add this other treatment in. We'll do some research on it first. To make sure that we can deliver that this really works for Chiari patients. Okay, so let me get out of that here, and we will go to the Q&A portion of what we're doing. Cheryl, do facet joints provide support for stability or is it primary ligaments for the neck? No, facet joints can also provide stability, but it's more the shape of the facet joints that provide stability. What I mean by the shape of the facet joints, just like I talked about the shape of the 0-1 versus the shape of the 1-2. The 1-2 would have very little intrinsic stability from the facet joint. The 0-1 would be different, for example. Have you seen one with eyelid spasms with CCI? Mine started after my accident. We have seen a few people with that. Yes, Cheryl. How long would an occipital nerve block last with orthobiologic injections for relief of CCI both treated? The goal of that kind of thing, Cheryl, is to go ahead and treat the nerve, meaning occipital nerve blocks are not what we do. An occipital nerve block is injecting some corticosteroid and some anesthetic. And what we're talking about here is platelet growth factors. So the first kind, an occipital nerve block, is merely just putting some anti-inflammatory in there. The second kind, injecting PRP and doing hydrodissection or platelet growth factors, is to try to help the nerve. So it would be much, much long-term. And obviously, if you get the nerve back online and get the muscle back online, then you may not need any additional treatment. That remains to be seen. Guys, let me go ahead and just stop for a second and make sure that everyone is like, comment, share, subscribe. Simply because if you found this thread and you think this information is helpful, you want to get it out to other patients. And the only way to get it out to other patients is to hit the like button, for example, wherever you are, because that tells the algorithm that other patients like you, people with your similar interest, might be interested in this kind of information. So do me a favor and do that. Also, I'm going to put a plug here in for the Reddit page, RPICL. So if you haven't joined the Reddit page yet, go ahead and do that. This is the Reddit page. If you're on Reddit or if you want to join Reddit, this is my own personal sub or subreddit where I answer all sorts of questions regarding CCI. People put stuff here, they throw their images here, they ask questions about the PICL, they ask questions about CCI, they ask questions about surgery, they ask questions about anything that has to do with anything with regard to craniocervical instability or the PICL procedure. As you can see, just hundreds and hundreds and hundreds of patients asking questions here, and they get written answers. So that's very, very helpful, I think, for many patients. So do me a favor and join that. We've got 251 members and growing now about 30 or 40 a week. So jump on there. Alexis, can Chiari get missed on an upright MRI? Usually not. That's usually something that they'll read for. And it's usually something that's pretty easy to define. I think there was a picture of it here. So if you just look at your upright MRI and go on the sagittal cut like this, and this line is a little high, it should be a little lower. So this line the patient drew should be a bit lower, but it's merely just dropping a horizontal line down like that. Now I've got a video coming up on how to measure this so that you can measure it yourself and take a look at your own images. Is 4 millimeter Chiari outside the frame magnum significant? It certainly may be significant, meaning that that's a CTE or Chiari 0. So again, by itself, it probably doesn't have any meaning. But if it's Chiari plus something else, then it may be a big problem, right? The something else without Chiari is probably no symptoms. The Chiari without something else is probably no symptoms. But it's those two that would cause a concern if you had a Chiari 0 or CTE. Mr. Nick, thanks for covering this topic. Happy to do so. Alexis, if someone had Chiari, would tight suboccipital muscles irritate it or create more symptoms? Alexis, I think is what we're talking about, and it's a good point to bring up, is that the tight suboccipital muscles can irritate that suboccipital nerve, which then makes the rectus capitis posterior minor muscle atrophy, which then takes away the ability to open the back door for that cerebrospinal fluid flow. So Chiari plus something else, in this case, the something else is tight suboccipital muscles that irritate the nerve makes the muscle go south, and then the back door doesn't open anymore. New Wave Brazil, would it be good or a bad idea to do general Aldua, which stretches the dura dynamically with Chiari present? That's a good question. That's a hard one for me to answer without knowing the patient. In some patients, that could provide some relief, perhaps opening that back door artificially. And other patients that are more sensitized, it could throw them over the edge. So that's one that depends on the patient. Ezra, does Chiari malformation happen in HEDS? I think it's more common in HEDS. So it's one of those things in the realm of HEDS, like CCI being more common. Jessica James, who are the 5 neurosurgeons? There's only 5 neurosurgeons. I think what Jessica is talking about is, I've said multiple times, really only about 5 neurosurgeons in the world that do about 80% of the elective craniocervical instability surgery. Those are Dr. Henderson in Maryland, Dr. Patel in South Carolina, Dr. Bolognese in New Jersey, Dr. Frank in Panama City, Florida, I think is where he is, and then Dr. Gillette in Barcelona. In my experience, those 5 surgeons do about 80% of the elective craniocervical instability surgery. Alexis, does an upright MRI show anything with CSF flow? Usually not. You have to have a specialized CSF flow study, and that would be Scott Rosa. So let's look up that here. So this is Scott's clinic. So Scott does very sophisticated CSF flow studies, as well as movement-based imaging. And but really what he's known for is focusing on cerebrospinal fluid flow in an upright MRI setting. So Scott would be the guy to see in the United States to try to see if there's an issue with CSF flow. Scott can also look at that rectus capitis posterior minor muscle. We've been in communication back and forth about it for the last couple of weeks since that paper came out. Ben, if a cervical collar doesn't alleviate autonomic symptoms, which are now constant after years, what does this indicate? Also, for someone with constant autonomic symptoms, general anesthetic safe. Generally, that may mean that the autonomic symptoms aren't coming from craniocervical instability, or it could mean that there's enough damage to the autonomic system that even taking the craniocervical instability out of the equation is not going to really move the needle. Now, general anesthetic and autonomic symptoms, not a problem. I would say probably about 1 in 4 to 1 in 3 of our current CCI patients that get not a general anesthetic, but they get total IV access anesthesia during our procedures. They don't have any issues with that. So that's not a problem. Now, when it comes to general anesthesia, that's with endotracheal intubation and gases, that could be a different story. I can only tell you what I do every day in patients with CCI and autonomic problems, and that's not an issue, and that's the total IV access anesthesia. KCN, why do surgeons rarely consider DMXs? Do they not consider dynamic of movement importance? Like in lumbar stenosis, they only look at static canal dimensions. Yeah, well, in the lumbar spine, DMX doesn't work as well because it's hard to push through. That's really more of a lumbar flexion extension x-ray, which many surgeons do use because these days insurance companies are giving them a hard time operating without some evidence that there is some instability, meaning fusion for instability. As far as DMXs and surgeons are concerned in the cervical spine, again, I think you're going to see those 5 surgeons would know what to make of a DMX, and they do about 80% of this elective surgery. Your average surgeon doesn't do this surgery, so he has no idea what he's looking at when it comes to a DMX. But those 5 surgeons will know what a DMX is. Alexis, how is type 1C initially discovered? Yeah, usually the best way, Alexis, to discover a type 1C is on flexion extension MRI or flexion extension CBCT. Those are the ways that a 1C is discovered. Ezra, I've personally been very curious over the years about how TENS unit can help with CCI pain symptoms, especially neuralgia. Could you shed any light on this? Yeah, Ezra, we don't have a lot of patients that use TENS units in our CCI or Chiari populations. So it seems to have kind of gone out of favor through the years. So I just haven't seen as much of it lately. Now, there is an interesting concept, right, there, and that is, can you externally or internally stimulate that suboccipital nerve? And could that get the nerve back? And that could be, using orthobiologics, our first approach would be treating with platelet growth factors. But maybe if that doesn't work, one way to treat it would be putting in a short-term external stimulator in that right muscle plane to try to stimulate it artificially for some time. So that would be an interesting one for sure. And it kind of brings up for me, your question brings that up for me. So thank you for the question. Zarko, what size of Chiari herniation is most commonly seen with CCI patients? Is there any relation? Most of our CCI patients have Chiari 0 or CTE. Some have Chiari 1, but just realize that at the end of the day, that probably just reflects the general population prevalence, meaning CTE is more prevalent in people walking around out there than Chiari 1. Oli Khan, can you please suggest some supplements for CCI? Oli, I'd recommend you go on that PICL Reddit page because I've talked about that quite a bit there. You can also go onto the Regenix page. Let's see here. Probably just type in supplements, I would imagine. No. Maybe that's not coming up that way. Apologize. Here they are, Regenix supplements. So it's under resources, Regenix supplements. So we did a bunch of lab testing a number of years ago. We added various supplements in with mesenchymal stem cells, and this is what we came up with. So you can also go to these and see, what sorts of ingredients are in there, and it talks about what's in there. And if you wanted to try to replicate it yourself, you could give that a shot as well. But that's supplements there. So going back to here, could a supine MRI show shallow 0-1 facet joints? It could. You'd have to have thin slices to do it. Many times you only get 1 or 2 or 3 slices through the 0-1 facet joints on an MRI. Therefore, a CT scan or a CBCT tends to be a little better for defining shallow facet joints in that equation that we talked about. Carol Yates, mid advanced by Chiari Scott. Can you treat Chiari? My local doctor wants to do surgery. Yeah, well, Sherry, that's what we've been talking about today. One option is to treat the instability. The other option is to treat the rectus capitis posterior minor and the suboccipital nerve. Obviously, in many of my Chiari patients, really the last 6 months, I've been treating that suboccipital nerve, primarily because we've been going after the greater occipital nerve in that specific plane, maybe the last year, and we've been getting some good results. Now, we've also been treating their CCI, so it's hard to say, is it treating the suboccipital nerve and or the CEI or the CCI or both? But we're about to embark on treating Chiari patients only in that suboccipital nerve for the rectus capitis posterior minor, and those patients specifically won't have any CCI. That'll be ruled out. Lala, how to repair an atrophied muscle? Can it become normal again? Yeah, Lala, we were talking about that. We want to go after the nerve supply, right? Because as you might imagine, you've seen patients who have spinal cord injuries and their legs shrivel up, for example. And no matter how much they exercise those legs, they're never going to get any bigger because the nerve is busted or damaged or hurt that goes to the muscle. So here, because the muscle is atrophied because of that suboccipital nerve, we have to treat both the nerve and the muscle. I believe it's possible, if the muscle is not too far gone, to actually get it. And so that's what we're going to focus on. Alexis, I think I talked about that. We're going to treat that nerve and the muscle. Submitted advanced by Harry Winston. Is the Chiari treated in the PICL procedure, or would a separate procedure be needed? Yeah, so that's a great question, Harry. I've been treating it now for quite some time. So we've been treating that nerve for quite some time in our CCI patients. So it is treated automatically if you're getting a PICL procedure, for example. And the same thing would be with posterior injections. We're going to be treating that now much, much more routinely if someone also has Chiari. But more importantly, if that rectus capitis posterior minor muscle is atrophied on their imaging, and you can generally see that on a routine neck MRI. So we can get to that, i.e. someone needs treatment of the suboccipital nerve fairly quickly and efficiently using their existing imaging without having to get new or fancy imaging. Christy, how do you know if you have Chiari? That's literally just looking at a sagittal MRI image, just like this guy was trying to do down here. He put that on the CCI subreddit, or I'm sorry, the not CCI, but PICL subreddit. So this is our PICL subreddit, not the CCI subreddit, but our PICL. And you draw a line across the foramen magnum. This one was inexpertly drawn. It needs to be further down. And then you drop a line down this way. If the cerebellar tonsil touches that line, then that's CTE or Chiari 0. If it goes below that line up to 5 millimeters, that's a Chiari 0 still. But if it goes beyond 5 millimeters, that's a Chiari 1. Mr. Nick, can you see RCPM atrophy on MRI? We had our original review visit your clinic late last year. I wonder if it's worth looking at MRI again with new research. Yeah, so you can see it fairly easily. Mr. Nick, I'll be in the office tomorrow and the next day. So I'm going to put the email address that goes to my work desk here in the comments. And drop me a line, and when I'm in the office, I'll take another look at your images and be happy to update you on the status of rectus capitis posterior minor. So I put my email address in the comments there, so you should be able to see that now. Lindsay, if the something else in the study could be Botox injections, the occipital muscles, could TENS units help reverse the muscle atrophy? No, I don't think so, Lindsay. If Botox caused the atrophy, then that's actually poisoning of the neuromuscular junction. So that's a whole other set of issues, and I don't know how to deal with that, meaning that if we poison the neuromuscular junction, and that's where the nerve meets the muscle, that could be a horse of a very different color, which is why I don't recommend Botox in any of these patients, because in general, it makes them worse because they need that spasm to hold things together. So that's a whole other thing. Liam, I've seen other people talking about their symptoms of confusion. I myself sometimes feel disoriented. How would that fit into CCI? Yeah, Liam, so I think what you're talking there mostly is about brain fog, and brain fog probably happens due to an ocular mechanism. And it seems non-intuitive, but we now know this to be true, that let's say you're trying to recall something, and just for the purposes of this discussion, let's say it's a car accident, right? And let's say you're out walking one day and you see a car accident and it's off to your right. So you hear the noise, your eyes go to the right, you see the cars hit. Well, if you're trying to recall that car accident a month later, what's interesting is that your eyes move to the right to replicate that and retrieve the memory. And without your eyes being able to replicate what they did at the time of the event, you have a hard time recalling that memory. It's the same thing when you've got craniocervical instability, because when you have upper cervical issues or craniocervical instability or Chiari, and that's affecting the upper cervical spine, then the input to eye movement is changed and becomes bad. So you can't replicate those eye movements very easily to recall. And I think that's what's probably causing the brain fog in many patients. Cheryl, Dr. Centeno, when I move my neck left and right, I have a lot of clicking and grinding. I don't test my neck, but I can't stop the clicking. This causes more damage to structures. Yeah, so the clicking and grinding can be caused by injury, usually to the C1, C2 joint based on what you're describing, or it can be caused by instability in the C1, C2 joint, or both. I would live your life as best you can, obviously try to get that treated. So I don't think I would go into a cervical collar to stop moving your neck, because then that's going to create other problems. Aaron, Dr. C, thank you. The healing has been superb from PICL4. Some months ago was my first EPICL. I no longer have eyelid spasm, face spasms, head, neck pain. Well, thank you so much, Aaron, for letting me know. Listen, I do what I do for feedback like that, right? Knowing that you've changed someone's life is very important to me. So thank you for putting that here. And I think what Aaron brings up is that when we modified the PICL and took it to the next level, this enhanced PICL is a game changer because I completely redesigned how the procedure was done. And no one outside my office knows how that happens or how that works. But it's a game changer because we can get directly within the tight band of the alar ligament very, very reliably now. There's two parts of the alar ligament, a loose band and a tight band. So prior to the EPICL and the rearrangement of how we did the PICL procedure, I would say we got into that tight band about 1 in 3 times. Now we're getting into it, or at least I'm getting into it 9 and 10 times or more. So it's a game changer in that we can now target much more efficiently the tight portion of the alar ligament, which I think will really, really help quite a few patients. JS, how do you choose a good PT for upper cervical? My first visit was, I'll see if there's more down here, JS, as we go. Brittany, how often do you see patients with ME/CFS, long COVID presentation, HEDS, no trauma, see them get better from PICL, additional treatment be needed? So Brittany, I would say that about 1/3 of our patients have an ME/CFS or long COVID presentation. About 1/3 of our patients have some form of HEDS or hypermobility, and they do well. Now, remember, each one of these treatments is individualized to what's going on with that person. So if, for example, you've got more autonomic features, we're going to go after that vagus nerve. If you've got this rectus capitis posterior minor issue, we're going to go after that suboccipital nerve. So that's in addition to the injections, the EPICL to stabilize. So that's what's happening there. So yes, we see those patients all the time, and most of them do quite well, but it's an individualized treatment plan for everybody. Thanks, baby. Time frame from treatment to muscle working again. Yeah, I don't know that we know that yet. We'll get there, meaning that this paper just came out 3 weeks ago. So we are moving at light speed to design treatments based on the research that just came out 3 weeks ago. I don't know that anyone else is moving at light speed to do that, but even at light speed, I can't answer that question yet. Brittany, how often do you see patients with ME/CFS? I got that already, Brittany. Canwell Deep, how do you know if tethered cord and lumbar instability is causing lower abdomen pressure? Yeah, I would say in all likelihood, it's probably a lumbothoracic issue more than it is a tethered cord, meaning that we commonly see patients with those sorts of symptoms. We treat their low back or lower thoracic spine, they go away. Obviously, that's not tethered cord. Let me take out just a quick second here, ask you to like wherever you are, because again, if you're watching this content and you think this content is helpful for you and you think it's great to have access to a doctor who's a specialist in this space and get to ask any questions you want, then please like, share, comment, subscribe, because that allows the algorithm to have other patients like you find this content. Also, do me a favor and go to RPICL Reddit. So if you just type in PICL up here, it'll come up, and join that, because we now have 251 members there and they're growing by 30 or 40 a week. Because again, I do this kind of thing 7 days a week on this Reddit, meaning I'm answering questions 7 days a week. It's driving my wife, I think, a little bit crazy because I'm constantly checking this thing and answering questions. But I think it's important, and there are literally hundreds of questions here that have been asked, hundreds of questions here that have been answered about the PICL procedure, about CCI, about Chiari, about here's my picture, what do you think? About, why do I have this symptom, et cetera, et cetera. It just goes on and on and on and on. So I want you to do both those things. Thank you. Let's get back to questions here. Christy, are you saying to get additional scan to the DMX, or this shows up on DMX. Christy, I'm trying to think what we're referring to there. No, yeah. So I think you were talking about Chiari. There is no additional scan needed for Chiari. Chiari is easy to identify. Upright MRI is the best way to do it, but you can also see it on a routine MRI. So if you've got either one of those, we're good in defining Chiari or even looking at that rectus capitis posterior minor. Those are not hard ones to diagnose. They do not need advanced specialized imaging usually. I don't know what all that is there. Zarko, if Chiari patient has CCI, is he more likely to have overall joint hypermobility? I think, well, it's a hard one to answer, Zarko, because about a third of our CCI patients have hypermobility. So if you're hypermobile, you're more likely to have CCI, just like if you're hypermobile, you're more likely to have elbow instability or knee or ankle instability. All of that kind of thing is what you're going to be more likely to have. So I don't know if I can answer your question the way it's worded. Cheryl, if someone had a PI syndrome recovered very well, no big flare-ups, would you use more BMC in the next treatment or PRP for facet joints? Yes, we do that all the time. I just did that this week, actually. I had a patient coming in for, I think, the second one. The first one was no big deal. They didn't even notice we did much of anything, meaning there was very little flare-up, and they wanted me to use BMC in the joint, so we did that. Again, I'm cautious there because it does, in most patients, cause a much bigger flare-up, and it did in that person too, but I think they got over it relatively quickly and efficiently. JS, what symptoms are a cause or maybe happen because of C3-4 severe canal stenosis, mitral neuropharyngeal stenosis on the right. So when it comes to stenosis at 3-4, usually you're talking about symptoms into the upper traps or burning into this area in the upper traps. Now, having said that, if you've got severe central canal stenosis there and there's pinching of the spinal cord, that can cause symptoms anywhere below that, and that includes into arms, legs, etc. So once you get into severe spinal canal stenosis, central canal, we're talking about a different ball of wax there. That's my email address. Someone had asked if I could check their MRI on file to try to see if there's rectus capitis posterior minor function or if it's atrophy, which I'm happy to do. Amy, can CSF obstruction be intermittent? Is it possible to have a normal cine MRI but actually have CSF obstruction that just wasn't detected at that particular time? It can, Amy, be intermittent. So at the end of the day, it certainly could be that in certain head positions. But again, I would have someone look at that rectus capitis posterior minor muscle, because if that's offline, then that's going to make everything that we're discussing here worse. But yes, it could be intermittent. Liam, do you think because the neck affects eye movement that the diagnosis of binocular vision dysfunction and CCI are directly related, as in the eyes aren't really working together? I do, Liam. Yeah, so your upper neck provides information to your brain about coordinating eye function, and those two have to talk together. There's also another message that goes to the inner ear, and actually all three have to be coordinated to have normal binocular eye function. Zarko, if Chiari 1 causes thoracic syrinx, is Chiari itself more likely to be cause of neck and head symptoms or potential CCI or RCP? Yeah, so Chiari, normally when it comes to Chiari, we're talking about a cervical syrinx. Just so everyone knows, a syrinx is in the middle of the spinal cord. There's actually a little hole, and CSF flows through the little hole. So the theory is that if you get a Chiari 1, for example, that Chiari 1 can cause some backup of CSF flow. Now we know it's Chiari 1 plus the rectus capitis posterior minor, because syrinx was directly related to symptoms and the denervation of that muscle in that recent study. As far as thoracic syrinx, that could be due to the Chiari or it could be due to something else. Now we're getting into a little bit harder to connect the dots. Thanks, babies, Chiari. I'm not sure what that means, but Chiari progressive disorder over a lifetime. For some patients, it is. For some patients, they will never have symptoms. Ben, if a constant autonomic symptoms are worsening daily, does this indicate treatment is required as soon as possible? Yeah, Ben, so if you're getting constant autonomic symptoms, and assuming those causes are CCI or Chiari, which is two of the things we're talking about today, then you'd probably want to get treatment sooner rather than later, because in my experience with CCI, for example, if you let it go and you don't get treatment, then those autonomic symptoms are get harder and harder to treat as time goes on. Ben, if the pain originated in the traps, what area of cervical spine ligament mass injury would this indicate? And would this cause breathing, swallowing problems? The breathing and swallowing problems are probably separate. Upper trap pain is really common in lots of different neck conditions, so not specific to anything we're talking about. HRH, talk more about Chiari Zero. Yeah, I have talked about Chiari Zero in the presentation, so I definitely recommend you go back, but that's CTE or Chiari Zero. And everything we're talking about today also applies to CTE and Chiari Zero as well as Chiari 1. Okay, guys, so we're coming up on the final 4 or 5 minutes of this presentation today. If you've got any questions, please put them in the comments, whether you're on Facebook or YouTube, and I'll see them here, and I can then answer them. In the meantime, again, do me a favor, if you haven't liked this presentation, please do so, because that's how people find this information. So if you thought this information was helpful for you and you want to pay it forward to another patient who may be struggling and searching for information like this, then like, share, subscribe, because that really helps the algorithm bring those patients to this information. The algorithm says, here's people who like this, and here's their profile, and here are their interests. And then if someone with a similar profile and interest tries to find it later, it's going to serve that up higher for that person. So let's see. When can CCI cause pins and needles in hands and foot? It can, but there's other things that can cause that as well. Cheryl, if someone got a PICL and you were conservative the first time with individual need to get in about 3 or 4 months, opposed to 6 months retreatment. Not necessarily. That would really be individualized to the patient. KCN, how do you prepare lysate before your 3rd gen improvement? KCN, we've been doing research on lysate for 20 years now. So we've developed a technique to get to the highest growth factor levels. I think that's what we're talking about with the 3rd gen platelet lysate. The initial way to create platelet lysate, and a lot of people still do that, is either with throwing it in the freezer and freezing it and thawing it. The problem is that doesn't get all of the platelets burst open to get the growth factors out. Another way some providers do it is with a releaseate. They add calcium chloride to clots and then they inject what's left over, but that doesn't get all the growth factors out either. So we've created a proprietary method to get all the growth factors out, or to maximize that growth factor content. Okay, guys, so we are right at coming up on 10. I want to thank everyone for participating today, asking all these great questions. Again, I believe very firmly that patients asking questions are how patients learn, and that an educated patient that knows more will do better than someone that doesn't know much. So I'd really encourage you to go to this RPICL subreddit and join that subreddit so that we can grow that community and you can get more questions answered 7 days a week. Obviously, I do this once a week. So I'll be back next week with another interesting topic. And again, thanks so much for being here today. Thanks so much for watching and asking all the great questions. Just feel good knowing that the question that you asked probably helped someone else, whether it was here today or whether it'll be when someone watches this, a week from now, because this will be on YouTube and on Facebook, in all likelihood, that question helped somebody. That question was probably similar to the one that they had, that they didn't get a chance to ask today. So thank you for those questions. And then one last question here. Marcia, is there a way to determine whether the Chiari has resulted from loose ligaments versus traction from a diseased phylum? So traction from a diseased phylum doesn't make sense in the Chiari side. Again, we don't really have any information that shows that a occult tethered cord is causing Chiari. We have more information that people are just born with Chiari, and that's probably what happens. So again, it's Chiari by itself doesn't really cause symptoms, but at least 0 and 1, versus Chiari plus something else is what causes the symptoms. Okay, guys. Well, thank you so much for watching. I'm going to end it up, and I'll see you next week. Thank you.